Welcome to the 11th Johnson's Baby Sense Seminar. The seminar is done in association with our media partner, yourparenting.co.za. What is normal? What is not? What's too noisy? What's too hot? What's that cough and what's that spot? Worry a little or worry a lot? Paediatrician Dr Claudia Grey will now shed some light on your baby's health concerns.
My topic today is more of a medical one. So I'm a pediatrician with a background also in allergies. And so I'll be talking to you more about the medical bits that you should know about your babies and when you worry and when you shouldn't be so worried. So your child's health, what is normal and what is not. We've already heard today that we'd love the babies to have read the manual, How to Be a Baby. And I think most of us had that expectation when we had our first kids. I certainly thought it would be easy. But the reality is there's no elevator to success. You have to take the stairs. And in parenting, it's exactly the same. It's a long, hard walk, and there might be a couple of running out of steams on the way, but it's worth it in the end. You achieve a very high goal. So my talk today is on what is normal, what is not, what's too noisy, what's too hot, what's that cough, what's that spot, worry a little or worry a lot. And an overview of the talk today, just so that you know where we're going and when you can fall asleep and when you might want to wake up. We'll first of all focus on the first few months because they truly are unique. Babies are very different in the first 3 or 4 months of life to later on. So there we'll talk about crying, a little bit about colic, stools, feeding, and development. After that, we'll be talking about slightly older babies and beyond, and a couple of illnesses. I'll look at each system at a time. For the very last few minutes, because I always run out of time, we'll just say a few things about allergy prevention, really dispelling some myths and ironing out some truths there. Seems that it is my clinical interest. So let's start with the first few months. By way of introduction, we suddenly have this baby and a massive new responsibility and absolutely no sleep. So this is a very, very tough time for all. We call it the 4th trimester. The first 3 trimesters are in utero, in the uterus. The last one is outside. So the first 3 months of life, our little human beings aren't actually quite ready to be born yet. And as a result, they have an immature brain and an immature gut. The baby's not really able to manipulate us yet during that time. And our task is really to make sure that our baby's needs are met and to establish a bond. Nothing more than that. Not establishing routines and worrying that the baby's not sleeping through. It's tending to the baby's needs. And as such, it's important to know the normal pattern of crying. So this is a crying curve. First 2 weeks, easy. He's been through it, easy. Granny says, oh, what a good baby, lovely. Week 3, all hell breaks loose. So all babies from weeks 3 to week 9 cry more, and that's a natural physiological phenomenon at an average of 2 hours a day. Some babies more, some babies less. And then this calms down a little bit again towards that magic 3-month mark. So that's physiological, that's a normal curve. And that's reflected here by the baby's curve and by the parent's curve. So looking at gripes and groans in these first few months, I've mentioned the immature gut, and I'm a firm believer that babies are overwhelmed with what they're fed in the first few months. So most babies have a degree of discomfort. And if you look at how much a baby feeds in comparison to their body weight, it's as if we're drinking 10 or 12 liters of milk a day. You can imagine how sore your tummy would be then. So we've heard this word colic, and it's loosely used as a term for fussiness. But the real old-fashioned definition of colic is crying for more than 3 hours a day, more than 3 days a week, for more than 3 weeks in a row. Everybody wants to know the cause of colic, and the truth is we still don't quite know, but we think an immature brain, an immature nervous system has a lot to do with that, coupled with an immature gut. But by definition, colic babies are thriving, they're growing, they're developing normally, and they will come to no long-term harm. except if you throw them off the balcony in frustration. But essentially, colic is a benign but frustrating condition. What are our management principles for colic? Well, first of all, don't overfeed the baby. The quicker the baby grows, the more uncomfortable they're likely to be. For the breastfeeding mums who've got a quick let-down reflex, they may need to lean back to control that. Lots of winding, lots of upright carrying, lots of pressure on the tummy. Movement, Meg has mentioned, driving, white noise. And if you need to use a medication, keep it simple and keep it safe. So I'm a big advocate of safe wind drops and maybe probiotics, but remember that the more potent colic mixture, so you get X mix for colic, most of them work because they sedate the baby. So they contain a sedating antihistamine, and we really need to think, is that really what we want to do to our babies in these first few months when the neurons are multiplying and forming their networks so quickly? So I always say to my moms, use these colic mixture for your crisis time, once or twice a day, but not as a matter of routine. And remember that time is the great healer. Mobilise Help, so have your on-duty strategy all sorted out with moms, moms-in-laws, husbands, etc. When do you worry about colic? Well, obviously you worry if your baby is vomiting or so uncomfortable they can't gain weight. If they're in extreme pain or constantly crying, if they're chesty with it, if they're developing severe nappy rashes, because you could have more complications then. Just a quick word on vomiting. Vomiting is normal, so babies are pukey little beings. And vomiting actually only peaks at 4 months. So when colic settles, vomiting can still get more. And as long as the baby is a happy spitter, you do nothing about it except up your laundry bills. But if vomiting is so bad that the baby is in pain or feed refusing or not gaining weight, then you need to see your healthcare practitioner, because we could have a reflux disease, we could have a cow's milk allergy, we could have a lactose intolerance. I'm not going to go into these further, but essentially talk to your healthcare practitioner if your baby seems to have more than just colic. Let's look a little bit about stooling patterns. We always like mentioning poo in the baby world. For those of you who haven't been there, we'll also have some graphic representation here. So for those sensitive viewers, this is a warning. In the first few days, babies pass meconium. This is the leftover swallowed amniotic fluid and enzymes that come from the gut, and it's thick and black and it looks like Marmite. Then it changes. Breastfeeding stools gradually develop and are usually mustard with little white seeds in them. Now, this is important. There's a huge variety. So some babies who are breastfed pass 1 stool a day. Some pass 10 stools a day. And some pass 1 stool a week. And essentially, this is a completely normal variant and a completely normal variety. If they're formula fed, we like them to pass on most days, otherwise they get constipated. So yeah, that's what I promised. That's a meconium stool, and that's a normal breastfeeding stool. Now, what is normal with the stooling pattern? We talked about the immature gut, and that includes the muscle of your anus. So that's immature. So for that to open, the baby has to do a lot of moaning and groaning and pushing and grunting. So for those of you who have babies, you know that when it's about to come, there might be a lot of red in the face. And you worry, is that normal? And the answer is, yeah, that's absolutely normal, because they have to put a lot of pressure on their guts for things to happen. Of course, it's abnormal if the crying is persistent and painful. They could have constipation, they could have torn their little anus. It's also abnormal if the baby has hard stools. That's not normal, that's constipation, and then you need to go and see your healthcare practitioner. A couple of words on sleep, and I'm so blessed that my next speaker is speaking about sleep, because it's a terrible topic to talk about. I call it the big issue. And so I'm not going to talk about sleep strategies, but I'm going to talk about the medical aspects of sleep, so sleep safety. Now, in the UK, where I did my pediatric training already 15 years ago, there was a big campaign of back to sleep, and we haven't quite twigged on it yet in South Africa, even so much later. Babies, the safest sleep position is on the back. And that's the safest in terms of minimizing the risk of sudden infant death or cot death. So the back to sleep is safest. This campaign has reduced cot deaths quite remarkably. It's more than halved them worldwide. Remember, the risk of cot death peaks at 2 to 4 months because a baby can't protect themselves that well. They can't lift their heads. They can't lift their heads if they feel that they're being smothered. And it reduces as baby has better head control and better muscle strength. So after 4 months, the risk is remarkably lower. This is put out by the UK Department of Health, the best way to get your baby to sleep. I've circled the ones that are realistic. Lie your baby on the back. The best place is in a cot next to your bed, and they actually recommend that for the first 6 months of life. Have the feet at the bottom of the cot, cover a blanket to the shoulders, and even offering a dummy has been found to reduce the risk of cot death, actually. And I certainly used this for after my first baby, but my first one, shame, he was shafted after a few weeks out of our bedroom. And now I know, actually, we have a medical reason to keep them in our rooms for a little bit longer. So what is normal in a baby's sleep requirement? This is important. Newborn babies sleep a long time. They sleep a lot. So up to 18 hours of the day. They only really wake for feeding and for nappy changes and bathing. In a 1-year-old, this is reduced dramatically. So drastically to 12, 14 hours per 24-hour cycle. And in a 3 or 4-year-old, you're lucky if they sleep their 10 hours at night, but they usually drop their daytime naps altogether. Now, one sleep cycle, so from going to sleep, going into deep sleep, coming back up into light sleep, takes about 40 minutes. And I think most of you will have seen this with your babies, that babies often come into light sleep after 40 minutes. So a lot of them wake up after 40 minutes in their daytime naps. A lot of our bad sleepers wake every 40 minutes to an hour at night because when they're in light sleep, they don't know what to do, how to get themselves back to sleep. But remember that for sleep to be restorative, to allow growth, to allow repair, you actually need to span at least 2 sleep cycles at once. That's why it's so important for us to try and get our babies to sleep beyond the 40 minutes, at least one daytime nap at a time, and at least a few times during the night. Night feeding may be normal up to 9, even 10 months of age. After that, it's generally a luxury. So it's generally a prop. It's what the baby knows to get them back to sleep. However, there are some babies that are allowed to feed for longer in the night. Obviously, those who've been sick, those who've been premature, those who are bad refluxes and have tiny tummies. Remember, the average baby has a tummy the size of their fist. That's how tiny it is. And if you've got a particularly small tummy, you can't drink much at once. So those kiddies may need more frequent feeds. So be adaptable to the needs of your baby. Another important thing, I talked about the 4th trimester, and I have so many moms saying, am I getting my child into bad sleep habits when they're 6 or 7 or 8 weeks old? The answer is no. We can't really manipulate their sleep patterns till they're over that great immature stage. So from 3 or 4 months of age, sure, we can try and start manipulating them, but not in the beginning. But even so, try and teach your baby some self-soothing strategies from the beginning. So, maybe a sensory cloth, etc., so that they know, okay, this is my signal for sleepy time. And obviously, if they cry, you respond to them. But many of them learn to self-soothe quite early, given the right tools. When do you worry about sleep? Well, any sudden change in sleep pattern, your kid may be ill, they may be going through separation anxiety, they may be teething, and this is not a good time to sleep train, clearly. Also worry if your child is not getting enough sleep. So if they're always ratty, their behavior may change, their development may be affected. The third reason to worry is if the parents are not getting enough sleep. Okay, so when people come to me asking about sleep, I always say, well, are you coping? And if they say, yeah, no, we're fine, they say, okay, well, then just wait for it to pass. But if the parents end up bursting into tears and hitting each other in my room, they say, okay, we've got to do something about this now. And that's the time to discuss sleep training with your healthcare practitioner. Let's talk a little bit about feeding in the first few months of life. So most babies have these small tummies that I described. They can't take much at once, which means we have to replace it often. That is why babies feed. I'd even say between 2 and 4 hours initially, because some babies are more frequent spend on the breast. Every time you see your clinic nurse or your doctor, they take the measurements, they fill in the chart, and they have a look at the curve, and then they say words to you that are, oh my word, what are they saying? Like your baby's on the 75th centile, and you say, okay. So, just to describe what we mean by the growth chart, this is an example of a girl's growth chart. We've got weight at the bottom, we've got length at the top. So if we're doing the weight, we plot it along this graph, but the fat middle line is what we call the 50th percentile. So that's the average line. It's called 50th because 50% of the population is above and 50% of the normal population is below that particular level. So if your child is average, they're on the 50th centile for growth. And that is why we plot our kids to see that they're staying on the same line. Even if it's a below average line, they may be petite babies, but as long as they're growing steadily on their curve. Remember that milk is the most important component of a child's diet throughout the whole of the first year of life, even when solids have been introduced. So even after 6 months, when they're eating their solids, babies should get, ideally, at least 600 mils of milk a day. Sometimes we have exceptions, and we need to have crafty ways of getting milk into them if they're not big milk drinkers. Over a year, the requirement falls because solids and a more adult diet become the norm with 3 solid meals a day. So then we can have 300 to 600 mils of milk per day. This is not a talk about solids, but I just wanted to put a couple of principles through, and I'm glad there are a couple of dads in the audience so that they can see what babies are supposed to look like when they eat. Mess is best. Variety is king. Fussy stages are normal. And try again. Studies have shown that babies introduced to new foods often need to be offered that same food 12, 13, 14 times before they'll accept it. So don't give up if they're not eating your favorite broccoli meal after 2 or 3 times. And this, ladies and gentlemen, is what I call a good solid session. Okay. A couple of words on development. When you go to your baby clinic, when you go to your doctor, they'll ask you a couple of things. Is your baby grabbing this? Is your baby saying that? And that's obviously for a reason. We want to make sure they're reaching their developmental milestones. Development has 4 pillars. We've got our gross motor skills. They're not that gross, but they're called general motor skills. So that's your sitting and your crawling and your standing and your walking. We've got our fine motor skills. That's hand-eye coordination. We've got our speech development, language development, that's self-explanatory, and personal and social interaction. So these are the 4 pillars of development that you should be asked for whenever you see your healthcare practitioner. They'll ask you about these aspects. It's important to know that the sequence of development is similar between children. So most children sit before they crawl, before they cruise, before they walk. But the timing is very, very different. And here, comparison is your biggest enemy. So if your mate's baby is walking at 9 months and yours only walks at 15, it doesn't matter. Yours may still win the 100 meters at the Olympics. Doesn't matter. It's a brain thing, not a physical prowess thing. Children also may be slightly more advanced in one area than in another. So we often see little boys charging around with their gross motor skills highly developed, but they can't hold a pencil, they just eat a crayon, and they say, duh, in response to questions, whereas a little girl may be very eloquent, but just be sitting there in a pile. So sometimes the skills develop in slightly different timings. And that's okay as long as they're reaching their basic milestones. Okay, so there are some red flags. I've got a couple here. Babies should be sitting by 8 or 9 months. They should be crawling by a year. They should be walking by 18 months, with a few exceptions. For example, those who bottom shuffle as their crawling style often walk only at 20 or 22 months. They should be starting to grab and mouth things by 4 or 5 months of age. They should be showing a pincer grip by a year. In speech development, they should be vocalizing and babbling and mimicking you a little bit by 6 months. By a year of age, we like a baby to have at least 2 or 3 words or pseudo words. You know, if they call the cat ka, but they do it consistently, that's a word, that's fine. By 2 years of age, they should be combining 2 words. Mummy, come, daddy, look, bye-bye, daddy, or whatever. Try and have 2-word phrases. In social terms, making eye contact, they should be starting to fix on you at your nice distance of about 30 centimeters by 2 months of age. So we often look for fixing and following at the 6-week check already. And a very good basic screening test for social disorders like autism is responding to their names by a year. So if you say Johnny, and Johnny turns around, yes, Johnny's socially adept by a year of age. Good. So we've dealt with the first few months of life, and that's the longest section by far, in case you're starting to panic that we've only finished one section. The following 2 are much shorter, and we're now looking at babies and beyond. So this is a little section on illnesses and what to expect and when to worry and when to relax. So the first thing to say is that most babies have many illnesses in the first 2 to 3 years of life. And that is because, number one, their immune systems are immature. Actually, just to clarify, in the first 6 months, we're protected by mom's antibodies that came through in the pregnancy. So often our babies are very healthy for 6 months. Then suddenly all hell breaks loose in the second 6 months of life because they're on their own with their immune systems. They have to make their own antibodies, and they're low. So babies' immune systems are immature, and secondly, every single bug they encounter is new to their systems. So when we have in contact with someone with a common cold, we've probably seen this bug 10 times before, we've got some kind of an immunity against it, and we may just have a blocked nose and be a bit grumpy for a day. But little babies will get the full-blown illness. And babies in creche or in daycare, or babies with older siblings, are exposed to even more bugs. So they will get sick even more often, and that's normal. The other thing is that most infections in children are viruses, and I'm sure those of you who've taken your kids to doctors often get told, oh look, it's a little upper respiratory virus, and you think, oh, what are they talking about? It can still be serious to have a virus, but the point is the treatment is symptomatic, so you can't cure it with antibiotics or anything like that. It's just a matter of time. Generally, when we talk about virus, everything is red and runny. Fevers are either low grade, like a cold, you may have 37.1, 37.2, or fevers can be spectacular. So with the flu, if any of you have been through the flu season with a child now, they can peak temperatures up to 40, then it drops, goes up, then drops. That's a very viral pattern of fever. Bacteria tend to be red and thick and pussy. So if the doctor looks in your child's ear and said, oh, I can see them pus behind the ear, that's a bacterial infection, not just a virus. So that needs an antibiotic. And they often have a more steady 37, 38 temperature, except if you've got a collection of pus like an abscess, then you can have a high swinging fever as well. So if you look inside this mouth, the doctor says, say, ah. If it's a virus, it'll be a little bit red and swollen. If it's bacterial, it'll be even more swollen and generally mucky. Okay, so generally we can see white spots or a white exudate. Now, don't be surprised if your child has up to 10 minor infections per year in the first 2 to 3 years of life. That can be normal as long as they're quite minor and not ending up in hospital or with pneumonias, etc. In addition, every cold can last up to 3 weeks. So a child can easily cough and splutter for 3 weeks after a cold. So it can feel like your baby is always sick. My baby is always sick. My baby is always snuffly. However, of course, if the infections are severe, like pneumonia, that is not normal and that needs to be seen to. Another tip is that children are often grumpy or difficult when they feel unwell. They may bite their siblings more. They may be less compliant, and often that means they're brewing an illness. Children have a higher breathing rate than adults. They breathe faster naturally, and they also have a higher heart rate naturally. Let's talk quickly about each system one at a time. The respiratory system. So when we talk about an upper respiratory system problem, we're talking about colds, throat infections, tonsils, ear, sinuses, larynx, or croup, which is in the upper airway. So everything here above the level of the neck is an upper respiratory infection. Then we go on to a lower respiratory infection. We're talking about bronchitis, pneumonia, and asthma. The common cold is an upper respiratory infection. It's generally self-limiting, so use the safest remedies and lots of hugs. Saline nose drops are safe. For short periods of time, decongestants are safe. Paracetamol, ibuprofen is safe. There's not much evidence for zinc. There's not much evidence for vitamin C. There is no evidence, and in fact a lot of danger, in the over-the-counter cough and cold remedies. So in England and America, they're banned under the age of 6 years. Once again, they're dirty mixtures. They've got sedating antihistamines in them. Their risks outweigh their benefits. Remember also to feed your child frequently with little feeds when they're sick. Call your doctor if they're not feeding well persistently, if the fever is high, and that's more than 38 degrees in the first 6 months, or more than 39 degrees in the slightly older kids, especially if the fever's been more than 2 days. Probably worth seeing your doctor. If they're unusually lethargic or irritable, that's enough reason to go and see a medical practitioner. Or if they're just not getting better after 5 days or so, even though they weren't that sick, it's worth seeing someone in case they've got a secondary bacterial infection, such as an ear infection. If your child is breathing fast, so more than 1 breath per second, more than 60 breaths a minute, that's pathological. If they've got a wheeze, or if they've got a whoopy croup sound. I'm not sure if these are going to work with a sound, but this is a child who's going to start wheezing. Doesn't look like the sound's working. Oh, there you go. Okay, did you hear that? It's a noise when you breathe out, whereas croup is a noise when you breathe in. Some of you will have had croup in the house. It's very frightening. It's almost like an exaggerated snore. That's a creepy sound. Let's talk a little bit about tummy bugs. Most are viral. That's why we say things have gone viral, because viruses spread like wildfire. Excuse me. Typically, they vomit for a day or two and then have diarrhea for up to a week afterwards. Your focus is on getting liquids in little and often, either a homemade mix or diluted juice or a commercial solution. It doesn't matter as long as they're drinking. If the child is active and drinking, they are coping. But diarrhea for more than 7 days, you may consider putting them on a lactose-free or dairy-free diet, because they can develop this thing called a lactose intolerance, which lasts for 2 weeks or so. Consult your doctor if the vomiting is persistent, the kid's not keeping anything down, the diarrhea is frequent or bloody, if the child looks drowsy, lethargic, or has a high fever and a rash. I think that's quite self-explanatory. For rashes themselves, these are difficult to self-diagnose. It's probably worth going to see someone if your child has a rash. Viral rashes are common. They're usually pink, and if you press down on them, they fade. Cradle cap is also common in the first few months of life, and the cradle cap rash can actually extend down the chest. This is a roseola rash. Child has a fever for 2 days. On the 3rd day, the fever comes down. They break out in a rash, completely benign. This is a child with a bit of seborrheic dermatitis or cradle cap, completely benign, non-itchy. That's cradle cap on the scalp. Consult your doctor if the rash is accompanied by a high fever, if the child is very unwell, or if the rash has red spots that don't blanch when you put pressure on them. So these are the spots we worry about in meningitis. They're called petechiae because they actually bleeds into the skin, not just a rash. So that's why if you put pressure on them, then you'll still see it. So that's the glass test here. A child with real meningitis, pressing down on the glass, you can still see the spot. Whereas a rash like the roseola one I showed you, you press down, you won't see spots anymore. So that's self-explanatory. You also worry if the rash is itchy and if it's getting worse over time. I think we've covered most of fevers. So if a child has a fever, we call the doctor. If they're irritable or lethargic, we're thinking about meningitis or urine infections now. If they're distressed in their breathing, if they've got rashes, if the fever's more than 5 days, or if there's a high fever for more than 2 days, it's worth having your kids seen. I've probably got about 5 minutes left, and I'll skip these few slides and really just talk about this last section here, and that's a little bit on allergy prevention. So what can we do during our pregnancies and the first few months of life to try and minimize the chance of our kid getting allergic? And this is important because allergies have increased quite spectacularly over the last 2 to 3 decades for various reasons which are not necessarily that clear, but are the subject of international research. So there's an allergy epidemic, and we've got also data to show that this is taking over in South Africa as well, in all our racial groups, unexpectedly. A child with no family history of any allergies, so that asthma, hay fever, eczema, gut allergies, food allergies, they've still got up to a 15% chance of having some kind of allergy. That's how rife allergies are in our community. As soon as you have a family history, so one parent or one sibling with an allergy, your chances are already 40 or 50% of having some kind of allergy. If you've got 2 parents or one parent and one sibling with an allergy, you're almost bound to have an allergic condition as a little baby sometime in their life. Now, allergy prevention strategies can be instituted because you'll say, well, if the genes are there, how can we influence it? Meg mentioned epigenetics. So epi means above, so above the level of the gene. So certain factors can change the way our genes are expressed. We can't change our genes, but we can change how they're read into proteins. And certain factors can play a role here and change how our genes are expressed. So during pregnancy, no specific avoidance of allergies is recommended. It hasn't made a difference. So the old notion of avoiding peanuts, etc., don't make no difference. The only reason why we say avoid stinky cheeses and shellfish, it's for infections. It's got nothing to do with allergies. Okay, so you can eat everything you used to eat. Try and have a portion or 2 of oily fish a week, so salmon or trout. That seems to be protective. And a generally healthy diet. Probiotics, omega-3 supplements are widely used. They may be beneficial. It's actually not 100% sure yet. But certainly it's not going to do any harm. Feeding the newborn baby, breast milk is best if possible. It has got some allergy prevention properties, but these properties are most in the first 4 to 6 months of life. So that's the most important time. Beyond that, no matter what you do, your child's allergy pathway is already set. So the first 6 months are where everything happens. We've also found that even though we love breastfeeding for as long as possible, after 6 months it's got no allergy prevention properties anymore. That's already done by 6 months of age. We also like moms to continue to breastfeed whilst the first solids are introduced, and in high-risk babies we'll consider a probiotic or a prebiotic. This looks promising, but we don't yet have absolute proof. So if you haven't done it, don't beat yourselves up. Worldwide, it's still a little bit of a question mark. Solids, basically, solids should be introduced when the child is ready, definitely not before 17 weeks of age. But this is important. There's no evidence that delaying solids prevents allergies, and this includes highly allergenic solids, peanut, egg. The children who come to my practice will know that by the time they're 6 months, I say to them, okay, now you can use peanut butter, etc. But after 6 months, you don't need to hold back, except if you've got a high-risk child, like there's a sibling with a nut allergy, or your child has eczema. Then rather see your doctor first, that food allergies can be tested for before you introduce them, but ideally still introduce them early. Also, don't smoke. And living on a farm in a dirty environment seems to be protective. And this last little comment, which is going to lead into our next session nicely, is that skincare has very recently been found to be probably the best thing you can do as an allergy prevention strategy. Children with eczema are at massive risks of food allergies, later in life also asthma and other allergies. So excellent skincare, keeping your child's skin hydrated, treating eczema early and aggressively is another very vital aspect in allergy prevention. We come now to the end, and I think we've seen the reality. There's no elevator to success. You have to take the stairs. But I think armed with a couple of tools, it's slightly easier to climb those stairs with confidence. But as we climb those stairs, remember to also let your children climb. Sometimes we cringe when children climb up jungle gyms, etc. It's important because life must be lived as play. These are my 3 kids climbing in the Kango caves. Mommy goes, ugh! But actually, it's the best thing that they can do. Thank you very much.
Mothering is our highest calling and hardest work. For the high and lows, Baby Sense is with you on your journey. Thank you for nurturing and touching the future. We would like to thank all our sponsors. Without their support, it would not have been possible.